Hello, everyone. Welcome to our lunchtime session. Lunchtime on the East Coast, I guess breakfast out on the West Coast. We're going to be doing Expanding the Focus, Patient Education from CME Providers. This session was generously sponsored by Platform Q Health Education. Let me bring up the slides so you can all see. And our moderator will be Wendy Terrell, Senior Director of Outcomes and Analytics at Platform Q Health Education. Few slides I will run through really quick, and then we'll get to the actual session. So again, a big thank you to all of our sponsors, our gold sponsors, Genentech, Platform Q Health Education, silver sponsors, CDI Meeting Technology, Educational Measures, iMedix, MedPage Today, and Paradigm, and our bronze sponsors, which I apologize, I was pronouncing incorrectly. It's ASIM, then Clinical Care Options, CMEology, Forefront Collaboration, Global Academy for Medical Education, Highmark CE, PVI, Real CME, Thistle Editorial, and Vindico Medical Education. As always, there are three ways that you can ask questions. You can either text us using our MedPage Today text line, 267-666-0CME. You can also click on the little Google Q&A link that's located at the bottom of the video. You need to have a Google account, but you can ask a question that way. That's pretty easy. And as always, you can tweet your question to us using the CMEpalooza hashtag. Lastly, our speaker disclosure slide. All of the opinions and discussions and conclusions expressed are our own and do not represent an endorsement by or a position of our employer, its parent company, or affiliates. So at this point, I will bring up the opening slide, and Wendy, I will turn it over to you to introduce the panel.
Wonderful. Thank you, Derek, and thank you, everyone, for joining us today. So I would like to introduce our panelists. We have Sarah Krug, who's the founder of Health Collaboratory and the executive director of the Society for Participatory Medicine. She's also the CEO of Cancer 101 Foundation. Sarah wears several hats. And we have John Scott, who is the senior manager at Genentech in the Medical Education and Research Grants Department. And Dr. Richard Beezer, who is the chair of professional education and also on the CME committee at Joslin Diabetes Center. And also Dr. Beezer is a clinical diabetes specialist at Joslin Clinic and associate clinical professor of medicine at Harvard. So thank you to the panelists for joining us. Next slide, please. So as you all may know, PageNet is not new. Obviously, PageNet in the CME community is what's new, and that's why we decided to put this session together and saw the need. Historically, our community, the CME/CE community, has focused on education of physicians and allied healthcare provider learners. And the information sources who put forth education traditionally for patients have not been CME companies, but have been pharmaceutical companies. For example, marketing departments have been active in that regard, public health organizations, the government, nonprofit organizations, and patient advocacy groups. And this education has been put forth in various routes, including a lot of print education traditionally back in the day, more recently direct-to-consumer television ads and online ads, promotional websites, but there's also websites worked by advocacy groups and other organizations and other online organizations that are becoming more prevalent every year. Next slide, please. So the change that has been going on in the past few years, I would say, in the past 2 or 3 years, what I've noticed is there's more of a growth being put forth by traditional CME products. So what are the differentiators? We like to think as a community that we're a more reliable and credible source of information. Look at our faculty, for example. We typically, I would say the majority of the programs put forth in our fields, we have faculty from esteemed universities, thought leaders in these areas. The programs resemble CME, maybe not physically, but in the fact that they're not product focused, the fact that they are fair balanced. But the way that we're conceptualizing these programs is evolving as we learn more about best practices in education. So today we've gathered this esteemed panel to discuss what these changes are and what the impetus for these changes has been. Why are these changes even occurring? Why is patient ed being put forth by CME providers? So we're going to start with Sarah Krug on our panel, and she's going to speak from the patient perspective. After she speaks, we'll hear from John Scott, who will speak from the perspective of a CME supporter, and Dr. Rich Beezer, who wears several hats, different perspectives we could hear from him because he's a practicing clinician who treats patients. He also is active and a leader in CME through Joslin Diabetes Center, and he serves on faculty for CME programs as well. So we thought that these different perspectives would help shed light on this topic. So,
hey, Wendy, I'm going to interrupt you really quickly. Can you do me one favor? Your audio is cutting in just a little bit. Can you hold up the speaker part of your headphones? Is that on? Do you have headphones on?
No.
Oh, okay. I'm sorry. Just try not to shake too much and look right out. For some reason, just every once in a while it cuts out, but we can hear you pretty well. I'm just chiming in.
Okay.
That's good.
Okay. Now we'll hear from Sarah.
Wonderful. Thank you, Wendy. So good afternoon, good morning, wherever you are. It's a pleasure to be part of my first CME Palooza. I will say that despite the tireless efforts of Derek and Scott, we were not able to troubleshoot my MacBook FaceTime camera issue, which is unfortunate because I am having one of those rare decent hair days, but I do have slides, and today I'm going to discuss patient engagement with a focus on the top 10 opportunities and pitfalls in medical education. And I'd like to open up by emphasizing that patient engagement is not new. It's work that's been underway for decades, which includes other theories and interventions and practices that have been studied and implemented across other areas of healthcare for quite some time. And this previous work has been repackaged under a somewhat new term of patient engagement. And although, again, patient education and patient engagement are somewhat new to the medical education industry, it's critical we leverage that previous work and the foundation that's already been built as we see these opportunities in the CME community. And we'll talk about this further as we explore the top 10 opportunities and pitfalls. If you could actually go to the following slide, please. Great. So we'll start with the top 10. So number 1, empower the patient by teaching the teacher to teach. And what's ironic about this is that the word doctor originates from the Latin word docere, meaning to teach. But how many clinicians know the difference between patient education theories and traditional adult learning theory? Just because a clinician is an expert in medicine doesn't necessarily mean that that clinician knows how to translate it into a language the patient can understand. With the advent of the internet exponentially increasing the free flow of information, we can research our condition, search terminology, seek advice. We can obtain feedback, motivation from sources and peers across the globe. And the digital age has really facilitated engagement and empowerment as e-patients are using resources to gather information. But then they come back to their clinical visit. And is the average clinician prepared for the e-patient? If you go to the next slide, please. Now, some of you have seen this diagram that I reference often, where traditionally we've been focused on the top 2 quadrants, right? The science of medicine, which includes components like evidence-based medicine, research, treatment guidelines, and then the art of medicine, which includes medical education, clinician competencies, their expertise, their interpretation. And now we've put a spotlight on the bottom 2 quadrants, where patients have access to more information through various resources, through tools. They have access to their health data. They're connecting with others on virtual communities of practices. And they're taking a more active role in their healthcare. And in addition, with an emphasis on the patient profile through personalized medicine and genomics as well, the inclusion of patient preferences and values, we're recognizing the importance of that and what the patient also brings to the table. And so clinicians are expert on medicine, and patients have an expertise on their day-to-day life issues and experiences. And to effectively establish a collaborative care model, we have to recognize the importance of all 4 quadrants. could go to the next slide, please. So number 2, avoid recreating the wheel and adding to the clutter and information overload by leveraging information that exists, partnering and integrating resources into longer-term solutions. So what does that mean? So we've been working on an initiative called the Magic Wand Project, where we asked the community if you could wave a magic wand and change one thing about healthcare aside from making it free, what would you change? And we've received over 4,000 responses to date. Many patients and caregivers complained about information overload. There's too much information for me to choose from. I'm overwhelmed with the amount of resources I'm given. I don't know where to start. And if you Google health education today, 694 million hits come up. Today, there are over 100,000 health apps available. There's already an overabundance of quality patient education, quality tools that are available across healthcare, with duplication of efforts taking place today. We know that a tsunami of information can confuse the average patient, and information overload has actually been linked to greater stress for health outcomes. So the advice here is that the CME community should not necessarily be recreating the wheel and building new patient education solutions, adding to the oversaturation of tools without first understanding the landscape. Let's not forget that what's new to the CME community is not necessarily new to healthcare. And an understanding of what's available needs to be conducted to avoid duplication of efforts. What's already working? How can you partner with organizations that already have solutions that have been working for years? And what's not working? How can partnerships potentially collaborate or come to fruition to address unmet needs? And then in addition, how do grantors assess the competitive landscape before providing support to what they might perceive as being a new idea? What we need is long-term interventions that keep the patient engaged over the course of their health journey, and there's so many programs out there that can be leveraged. A component of the Magic Wand project that I mentioned is also to map the various solutions and resources that are already out there to the issues that have come in from patients and caregivers across disease states. So this allows us to not only put a spotlight on the landscape, but also helps identify where there might be opportunity for new innovations to address that unmet need. I always say that innovation isn't about creating a shiny new car, but rather it's paving a smoother path for that old car to travel down, and we need to take that into account as we embark upon the path of patient engagement. If you go to the next slide, please. Number 3, arm the patient with the tools to succeed. Give patients a prescription to learn to allow them to become architects of their own success. Now, back in 2007, Cancer 101, which is a patient advocacy organization that helps over 100,000 patients and caregivers navigate the care journey through partnerships with over 1,200 hospitals and community practices, began using prescription pads with our partners, which we called a prescription to learn. And the clinician would prescribe various resources to the patient using the prescription pad, which included our Cancer 101 navigation toolkit. We added a QR code to the prescription pad back in 2011 and found that 95% of our patients were actively filling their information prescriptions. And we recognized that many clinicians weren't aware of all the resources that were out there based upon preferences or phase of the patient. We also recognized that as patients went searching for information online, they weren't sure which resources might originate from credible sources. And the Prescription to Learn program has launched an electronic version where we have included cancer-specific resources to begin, but we're working on other disease states behind the scenes. And I'll show you some screens here. If you could go to the next slide, please. Okay, so Prescription to Learn is essentially a health GPS that cuts through the clutter and allows a patient or a caregiver to navigate resources from credible sources based upon their personalized search criteria. And the user would first indicate what condition they needed information on. So in this case, they would select breast cancer, for instance. And if you go to the next slide, they would then indicate the phase of the journey they're interested in, whether it's prevention, newly diagnosed, treatment information, clinical trials, or long-term management. You'll go to the next slide, please. They would then be brought to a screen to indicate their medium of choice, a website, a book, a brochure, a mobile app, an online community, a video. Next slide, please. Their personalized search would then showcase resources from credible sources with information on each. They can see how other patients, other caregivers have rated each resource, in addition to how a clinician, whether it's a doctor, nurse, a patient educator, may have rated that resource. In addition, we've been working with Mayo Clinic and MD Anderson on a meaningful partnership continuum, which essentially peels back the layers of patient engagement, recognizing it's not a one-size-fits-all approach. And we've essentially created a 7-phase continuum. So each resource in the Prescription to Learn system is actually tagged with the phase in that continuum. And this truly allows us to understand the information-seeking patterns and navigation behaviors of the patient or the caregiver based upon, again, their phase in the journey. And we're also working on understanding certain behaviors such as distress, which can trigger additional interventions. You can go to the next slide, please. So now the clinician or the health extender, again, the nurse, the doctor, the patient educator, can also prescribe resources through the system. The patient or the caregiver can fill the prescription, but then also navigate to additional resources that they're specifically interested in. We've also begun to integrate this into CME activities so that a clinician receives medical education on a specific topic with recommended resources to prescribe to their patient or to their caregiver on that specific disease state. And then we can obtain patient-level data on fulfillment of the information prescriptions, but then also navigation behaviors of the patient or the caregiver with the meaningful partnership continuum I mentioned as the backbone to that. If you could go to the next slide, please. All right, number 4. So number 4 is recognize that there's a science to patient education and engagement. I can't emphasize this one enough. There are educators across the healthcare system that have utilized various methodologies to educate, to motivate, to engage the patient. Again, patient engagement is a new buzzword that's describing what's been done in the field for years. There's been a vast evolution of tools and interventions. And what can we learn from that? Patient engagement is not equivalent to patient activation. Patient engagement is not just about simplifying medical education for the clinician and putting in pretty pictures. Patient education is not simply what we know about adult learning theory. Patient engagement and education is not just about changing behaviors, and majority of patients are not motivated learners. Let's not forget that patients are sometimes thrown into the world of healthcare overnight, where they're forced to make life-changing, life-saving decisions. And that emotional upheaval can take a huge toll on that patient and their family. And again, there's so many layers to educating and engaging the patient. And as per a recent assessment conducted along with field interviews, many medical education providers don't necessarily have expertise in this field, which is why partnerships are so critical. In addition, I mentioned the collaboration that's currently underway with Mayo Clinic and MD Anderson to develop the standard tool to assess the impact of patient education along the care continuum, utilizing these meaningful measures. And many organizations, we actually conducted an assessment where we found that there were hundreds of measurement tools that have been utilized across healthcare, where many organizations are also utilizing custom measurement tools that tie to quality improvement efforts or institutional targets. More recently publicized, there's some proprietary tools around out there like the patient activation measure that aren't being utilized by patient educators in the field due to the variability and applicability to some chronic illnesses. So in any event, patient education continuum scale has been created, and we're working on the measurement scales around each phase now based upon the science of patient education and engagement. Next slide, please. Okay, number 5. Incorporate the voice of the patient into the creation of solutions from number 5 is incorporate the voice of the patient into the creation of solutions. It's critical. So patients and caregivers have a powerful role to play in designing, developing, and enhancing innovations that were created to serve them. The expertise of the patient, the expertise of the caregiver cannot be learned unless you've walked in their shoes, and it's not something that you can learn through a literature search. Go to the next slide, please. I'm just going to talk about the Patient Shark Tank briefly, which is a platform that was created to amplify the voice of the patient or the caregiver, where innovations are assessed by the patient and caregiver. They use a co-designed scorecard to assess the innovation, and that allows you to incorporate important perspectives into the design or even continuous improvement of the patient-focused intervention. We've even put our own Cancer 101 navigator in front of the patient Shark Tank, something that's been around and evolved since 2002 and shown positive results in improving patient outcomes. But we received such valuable perspectives and feedback that we've begun to incorporate it into the new version of the planner. So there's over 600 patients that are part of the Patient Shark Tank across disease states. The Patient Shark Tank's evaluated patient education strategies, new tools, resources, websites, technology for academic medical centers, medical schools, medical education providers, and pharmaceutical companies. In addition, the Patient Shark Tank has gotten involved in grant reviews where they're evaluating specific patient-centered innovations that are embedded into a large curriculum and to ensure that their perspectives are accounted for. And then in addition, there's a patient shark tested seal that's provided to those initiatives that have gone through the patient tank. Can you go to the next slide, please? Number 6, use a baby step approach to integrate a new way of practicing medicine and implementing change. Now, we need to recognize that the average clinician is overwhelmed with new federal mandates, EHR implementation, other requirements. Many clinicians are actually leaving practice as a result, and there are many studies citing overburden. And our role should not be to introduce new methods of practicing medicine and shared decision-making models, but our role in the CME industry should be to really figure out seamless integration into daily workflow and team-based and system-level approaches so the burden doesn't fall on the shoulders of the doctor. Also, change to daily workflow and behavior change overnight is difficult, so a baby step approach is important here. If you can go to the next slide, please. Number 7, go beyond the literature search and integrate real-world data to identify and design solutions. There's so much we can learn from real-world experiences. Let's move beyond what we learn from literature searches and get out in the field and learn where there might be unmet needs and local barriers that we can truly address. Number 8, please. Number 8, an N of 1 is reflective of one patient's experience, and patients are not one size fits all. Now this one is pretty much self-explanatory. We need to move away from, again, these one size fits all solutions, and just because you've included a patient or a couple of patients on an advisory council or obtained feedback from a couple of patients on an intervention does not mean this reflects the perspectives of others within that same disease state. You know, we've done extensive journey mapping across disease states and found tremendous variability in behaviors and attitudes and have identified key trends along the way. And so it's important we understand that we have to move beyond the one patient or the couple of patients that we've integrated into our interventions. Number 9, understand and integrate the explosion of healthcare innovations into the point of care. So I mentioned the countless apps, and there are thousands and thousands of organizations out there focused on educating and engaging the patient. Let's move away from recreating the wheel and take the time to connect the dots and synergize solutions. Let's not add to the white noise and really focus on solving problems and barriers. This is the health match. I mentioned the matchmaking we're doing through the Magic Wand project, so if you're not sure what's out there or where to start, ask. I'm always happy to go on a walkabout with any of you who have questions. Number 10, last but not least, healthcare is complex. Our goal should be to simplify it. If our goal is to truly improve health outcomes, if our goal is to truly put patients first and help the clinician achieve this as well, let's evolve into educators focused on addressing barriers and true unmet need in order to gain the respect the CME community deserves. Let's not think about patient engagement as a business opportunity, but rather an entity that will use a system-based approach to connecting the dots and really troubleshooting the barriers through solutions that are out there and new interventions that we can co-create. Mm-hmm. Thank you.
Wonderful. Thank you so much, Sarah. That was wonderful information. Could you tell us how CME providers can get their ideas and grants submitted to the Patient Shark Tank?
You can send me an email, sarahkrug@cancer101.org, or you can actually go to patientsharktank.com.
Great, thank you so much. Okay, we're going to move on to hear from John Scott, who is Senior Medical Education Manager from Genentech, who will speak from the perspective of a CME supporter.
Thank you, Wendy, and thanks, Sarah. I find it interesting that you reference patient engagement from 2 decades ago. And recently, yesterday, we had a conversation in-house here about an article by Quinn in 1996 that discussed patient engagement. And it's striking that really we have had no components of patient ed other than some patient tool pieces in grant submissions that we've had. So, and I think from a supporter perspective, and any supporters that are on the line, I'm sure they have patient care in a portion of their mission of the company, and our goal is to really add healthy days to patient lives. So next slide. One of the issues that we see currently is that only 55% of the patients, on average, receive healthcare that is recommended for their conditions, and it's really substandard, I think. And for clinical evidence to get put into practice in 17 years, I mean, that's way too long. So how can we improve that process? So education to drive a system-based learning, which can be critical to improving patient care. Why don't we bring the patient into the mix and hopefully provide better patient outcomes? Next slide. I'm sure everybody is familiar with the former IME model where you have butts in the seats. It's passive learning. Was the chicken good? That's not good enough any longer. And the current expected IME model in closing healthcare gaps will be all-inclusive of these 4 buckets that you see on the right of the screen. Certainly changing practice patterns, knowledge and confidence of the practicing clinician, and now in the last couple of years, the quality care, and in the last year, patient engagement. And that's going to be a key role as with the ACA on the forefront. You know, the patient is becoming more and more important to the education process. So, next slide. We're all familiar with Moore's outcomes, and it addresses the design and outcomes analysis of individual healthcare providers and patient needs. And the individual healthcare provider and individual educational provider will define, you know, what the patient impact means to them in relation to the educational program. But now we're in a systems-based decision-making world, and it's not only about adult learning principles, but also behavioral theories. And it's important to understand that the physician may not have the skills to interact with the patient effectively, and vice versa. And so that's something that we may want to see addressed in the submissions of grants. Next slide. The national quality strategies have come into play, and it's all about vehicle for education, and you can address patient and family engagement in this process so that you know, we are all users of healthcare. And if you think about if you've gone to a clinician in the last year or so, you've probably received a survey back from that practice, you know, asking you to rate the clinician and the service that you received. And that's one form of patient engagement, and it addresses some of the national quality strategies that are in play. But it certainly can be built on to be more than just a survey. So next slide. Shared decision making is coming to the forefront, and you know, we'd like to make decisions not only with the healthcare provider because of their knowledge and confidence, but also put expectations onto the patient, and so that they can be fully informed and equipped to make appropriate decisions in their healthcare. And so that there can be an interaction between the two components, both the healthcare provider and the patient. Next slide. Activating that patient, you know, a lot of patients don't have the desire to be in their treatment process, but it really is a necessity now with the ACA. And the patient should be more engaged with the clinician, and they will provide needs and preferences of the abilities and are used, and self-monitoring, self-management, and the more engaged that the patient is, the better health care that patient will receive, we hope. Next slide. What is SDM in the context of MedEd? And not every grant might have shared decision making. You know, that's up to the provider, but it's adding patient education when it's appropriate. And the ultimate goal is to improve patient health outcomes, improve quality healthcare, and decrease the healthcare costs. So everybody benefits. The physician is educated on how to provide better engagement with the patient, and the patient's increase in knowledge of the treatment process and the benefits of the treatment, and how they can more appropriately move through their care process will be beneficial for all. Next slide. You know, some of you may have recently been at the quality conference that was held in Chicago, and the TELMS model was introduced there by Caroline Robinson and John Ruggiero, and it is a systems-based learning process. And if you look at the right side of the bucket, it's on patients and caregivers. How can we improve their awareness? How do we convert the information that they receive from the physicians so that it's understandable for the patient? And how can they take action on the information that they're provided from the healthcare provider? And if they're able to engage and take action on that, and better partner with either the communities that they're in, and also with the healthcare providers, you know, patient care will increase and improve dramatically. And next slide. Our ultimate goal is to add healthy days to patient lives. Thank you.
Thank you. Thank you so much, John. And we've been told by Derek that we will be able to post the white paper that describes the TELMS model John referred to in the resources section of the CME Palooza. So we'll figure that out, and if we can, we'll add to the comment section as well some instructions on how to get that as a resource. So we will now move on to Dr. Richard Beezer, who will speak from the perspective as faculty member, CME chair from Joslin, etc. His multiple roles.
Thank you. Thank you. It's a pleasure to participate today. I'm going to tell you a little bit about a project that we are just completing that tries to bring to the fore some of the principles that we've talked about in this last hour. This is a program focusing on diabetic retinopathy that has an accompanying patient education series. Next slide. There are multiple components to this program. We had sessions, and by the way, this was hosted on the Platform Q delivery system, which provides programs that run close to an hour, real-time video with endured versions, and the faculty has a moderated discussion, and the opportunity for learners to send in questions is there as well. So it's a very nice platform for interaction and for creating sequential education. This particular slide shows how we designed this program. We kicked off with a program for specialists on diabetic retinopathy, then had a program for primary care providers, then had a program for patients, then went back to the ophthalmologic specialists and ended up with a program for patients. The goal here is to design aligned education and try to move the needle on actual performance of providers and actual behavior by patients all at the same time. Next slide. The goal, what we're trying to accomplish here, is fairly simply to get more people with diabetes to be seen by ophthalmologists regularly. because early eye disease has no symptoms, and the only way you can pick up on it is for people to have examinations and to have the retina looked at and intervened on if there's problems. So to that point, the second objective is to have ophthalmologists screen for the presence of early diabetic retinopathic changes so that these interventions can be accomplished early. Next slide. The goal here was to design this as a tri-level approach to education, because we believe, as has been discussed already, that there are many stakeholders in actually changing the performance of the healthcare system. We've all struggled with performance improvement CME, and how do you try to change behaviors and change outcomes through what's really a complex system of providers and patients and care systems. And we're hoping that by getting it to a tri-level system, we can begin to start approaching more than just one segment here. So we look at this. We have the ophthalmologists, who are the specialists that are providing the treatment. We have the primary care providers, who are the ones that are actually sort of the traffic cops that are directing and promoting the patients to go to see their specialists, and the patients themselves, who are the ones that are receiving the care but are also making those key decisions for their own health that are part of this whole process. Next slide. Now, just to give you an idea as to how we design this, I'm going to show you a couple of aligned learning objectives. And again, we tried to design these learning objectives so they fit the learner. So for the specialist, for example, this is, how do we set the stage for reducing the morbidity relating to eye disease? For the specialist, implement a strategy for comprehensive approach to diabetic retinopathic management and integrate a patient care model. So how do they set up their systems to be more effective in intervening? The primary care provider, identify risk factors for developing retinopathy in diabetic patients, such as metabolic abnormalities, glucose management, blood pressure management, and try to intervene early and also direct patients for care. And for the patients, what can they do to help ideally prevent retinopathy, but if that's not possible, then at least slow down the process and get to care in a timely way. Next slide. Another objective, or aligned objectives, is looking at the actual process of care. So from the specialist perspectives, can they assess the patient to determine the most appropriate course of therapy for the retinopathy and develop treatments that are up-to-date, state-of-the-art to address this problem? The primary care provider, do they know what the guidelines are, what the screening recommendations are, and how they can be a facilitator in making sure this happens? For patients, they need to understand the importance of getting their eyes examined and what the treatments are all about so they can make informed decisions and be self-motivated to seek these cares in an appropriate way. Next slide. Now, the content was also aligned. I'm not going to read through all of the details here. You can see these now or in the endured version. But we, for the ophthalmologist, designed programs that focus on what they need to think about in looking at diabetic eyes and deciding on potential treatments based on the findings, and how they can better integrate with the other constituents in this educational process, the primary care doctors, the patients themselves, so that we get the ophthalmologists out of their box of just looking at eyes and dealing with the entirety of the care delivery. Next slide. Primary care providers are really key as well. Oftentimes, primary care providers, if they think about eye disease at all, have a checkoff box on their review of systems. Have you seen the ophthalmologist? And in fact, oftentimes patients may say yes, but is it really an ophthalmologist? They may have just gone to have their eyes refracted for their new set of eyeglasses. So do they know how to ask the right questions? Is this person that looked at your eyes dilating the eyes, looking at the back of the eyes, talking about your retina as part of that examination? So these are part of the strategies that primary care providers can take to make sure that the care is really what it should be, and understanding those guidelines for that sort of process. As well, patients have a lot of barriers, and we'll talk about those in a moment. But the primary care providers need to understand what those barriers are and seek to overcome them. Patients fear blindness, fear vision loss, and oftentimes people respond to fears by avoidance. If the primary care provider can recognize that, they can begin to try to break down those barriers and get that patient moving towards ophthalmologic care. Next slide. From the patient's perspective, it's really a complex learning process. First part of this was to have them hear what the ophthalmologist and optometrist on the faculty said about diabetic retinopathy, so they understand what it is. They have this image, perhaps, that this is blindness, it's a bad thing, it can happen to me, it's a sort of Damocles hanging over my head. But really understanding what it is, what the natural history is, what they can do from an ophthalmologic perspective makes a big difference in how they engage themselves as part of the process. But here on this slide, we also tried to engage them in speaking up, empowering them to ask the right questions of their eye care professionals and understand what their role is in the process. In the second of these programs, which we conducted just a week ago, we had 2 patients on the panel, one who had not yet had any, or hopefully never will have, diabetic eye problems. The other one had been through significant treatments. And we had them interacting. The patient without the experience was asking questions. What was it like? What were your fears? What were your concerns? And the other person was responding, and they engaged in a wonderful conversation that helped patients get a sense for what this is all about and how they can deal with their own emotional reactions to these situations. And also the patients and the physicians interacted. Oftentimes a physician interaction with a patient is the patient being asked questions by the physician and the patient sitting there passively just trying to give them the answers. But here we tried to get the patients to ask the physicians questions so that they could better understand what was going on and pull information from the patient, from the physicians themselves. So part of this process is teaching the patients the process themselves of how to be more effective consumers of health education or health care. Next. This next couple of slides gives you a sense for the flow of the program, the patient program in particular. This is the engaging first screenshot that shows, tries to attract patients into this. What is it? Are you at risk? Getting their attention. Next slide. Next slide, yeah. Here's a picture of Evelyn, one of our patients. She's the one that's not yet been through the experience of eye issues, but she talked very nicely about her experiences with diabetes, what she's done to try to prevent eye disease, dealing with her metabolic issues, dealing with sugars and blood pressure, and getting regular eye exams to prevent eye disease from getting ahead of her. Next slide. This is Dr. Murtha from the Beetham Eye Unit at Joslin Diabetes Center. He talked about, from an ophthalmologic perspective, what you as a patient can do to help prevent and control diabetic retinopathy. Give the patient some empowerment to do something for themselves rather than passively sitting back and saying, well, this might happen to me, nothing I can do about it. Yes, there is, and he went through that. Next slide. And then Dr. Deborah Schlossman talked about what retinopathy is specifically itself from the level of what's important to a patient, what it is, how it affects them, and what sorts of things they can expect in terms of care. Next slide. We then had a nice discussion about what an exam is all about, dilated eye exam, what to expect, what it feels like, and the patients talked about their experiences. In the second program held last week, we did a similar thing as people that have experienced this talked about what the treatments are like, the laser treatment, the injection therapy, and so on, and sort of demystified some of the processes and reduced some of the fears that people might have about what this is like from hearing from someone who actually went through it. Next slide. We had a lot of engagement. People, as you can see here, for the duration of watching this, a lot of the learners stayed for a lot of the program, and this is just average numbers. A lot stayed right through till the end. We had a lot of questions. Next slide. We asked the patients some questions. Factual questions. This is again a false statement that there are symptoms. In fact, there are not. Next question. Next slide, rather. And this showed, is there a call to action that's being responded to? Do you plan to schedule an eye exam soon? And 88% responded yes. And that's really one of the goals that we're trying to bring forward in this program. Next slide. There are a lot of very good questions here, and I'm not going to read through all of these, but you can look back on the Endured version of this program and see what these are and look through them. From specific questions about macular degeneration to number 4 there, an experience someone might have had and wants to know how that applies to them. Next slide. Some very pointed questions, specific treatments. Does an optometrist, like the one you see in an eyeglass store, count as an eye doctor? Well, optometrists are very important. We had one on our faculty, but an ophthalmologist is the one that actually does the eye exam. This is a really important distinction for people seeking care. So I think that's an important thing to get across. Next slide. And here are some other ones, again, more about treatments. And again, I like number 16, a catharsis. I think just having patients hear some of these things discussed and addressing some of their fears that they've had bottled up and have not felt that they could ask is important. And part of this, again, is to empower them to ask their primary care doctors or their eye care professionals to see if they can get this catharsis with their direct care providers. Next slide. So from this, we've had a lot of challenges and a lot of learnings. We did 2 of these patient education programs as part of this series, as I showed you in the outset. And we took the experiences in the first one and really applied them to the second one, trying to improve on some of the key points, empowering patients, demonstrating more conversation, etc. So some of the challenges in developing this tri-leveled programs is this. How do we properly align the content? Designing and aligning the content for the various audiences. We've tried to do this, as Sarah pointed out at the beginning. You can't talk the same way to patients as you can to medical professionals. You need to engage them and empower them. And how do we do this in an aligned fashion? Is there a way that we can use the content to bridge the conversation and communication between these constituencies? And I think that's part of what we tried to do. Is there a specific order? If we have a closed constituency, one healthcare plan, that may make a difference. Having patients and providers in a various order to try to stimulate communication. And how can we follow up on this to gauge outcomes, and what measures of outcomes are the most important in seeing if this is effective? Next slide. Some of the implications are, is this a new way of dealing with the conundrum of performance improvement? Because that seems to be more difficult to really accomplish, considering the various levels of engagement of various constituents in the healthcare delivery. And are there various recipes for various topics of combining different types of multi-level education? Specialist, primary care, primary provider of care for the condition, and patient was what we did for this program. But other topics may lend themselves to some of the others on this slide: primary provider of care, educator, patient, specialist, primary provider of care, educator and support team, and another one that I think is very important: primary provider of care, patient, and administrative team members. Are there obstacles to the structure of a practice that need to be overcome in order to make things flow more importantly? And I think that sort of approach needs to be looked at if we're going to take this model and bring it forward to be able to help educate within a health plan where you've got a self-contained group, and can we develop care within that group and then gather the data to demonstrate that this is cost effective. So that's sort of our learnings and our impressions from having tried this, and I'd certainly be interested in hearing people's responses and reactions.
Thank you so much, Dr. Beezer. So you highlight a program here where the content was aligned with physician education and patient education, or different physicians specifically. Do you think there's a role in CME for a solo, standalone patient education programs?
Look, there's always a role for standalone education for all of these constituents. I mean, you take the constituents that are on that slide: specialists, primary provider care, educators, patients, administrators. The standalone is always useful, and I don't think that's going to go away, or should it go away. But I think we can explore how we can more effectively impact actual performance behavior by seeking to align these things. So I think there's room for all of these as we think about what we want to develop going forward.
And Wendy, I'd love to answer that question as well. I think it also depends on your stakeholder group. And so, you know, I mentioned the need to incorporate a team-based approach to engaging the patient where the burden can't be on the clinician. And if you're rolling out a CME activity on diabetes or breast cancer, for instance, and then also including a component that's focused on educating, engaging the patient with patient education resources, again, we need to ensure that that education also reaches the nurses, potential patient educators, others across that continuum. So again, it's not just focused on the doctor having to now, again, practice this new way of medicine. And so I strongly am an advocate for standalone education as well, because it serves a very different purpose. I think there can be the aligned education for certain phases of this, various layers of this, but the standalone education, I think, can also be quite effective.
Mm-hmm. Mm-hmm. Okay. And I have another question for the whole panel. What is the future of patient ed in CME? Does this model have legs? Are this community going to be providers of education moving forward, or is this a trend that we're seeing?
I'll take that first. I guess from the supporter perspective, you know, certainly budgets are an issue, and I think this type of education does have legs and should continue, but not every activity is going to look like this. So, you know, while this was a fairly high dollar support activity, we're not able to do that. I'm sure other supporters are not as well for every activity. But, you know, if we can incorporate some of this in some of the grant requests that we see, I'm sure that most of us are willing to support great education like this.
If I can jump in also to John's point, I think it's a very important point. And that was the whole key to that last slide, where I looked at the various combinations of learners. Performance improvement CME has to move to a new level, and I think this may well be it, because changing performance is so complex. So I really hope this has legs. The cost is a challenge, and I've been very appreciative of the pharmaceutical support that we've had over the years, and not just support to run a program, but support in terms of exploring these new ways of doing education in a way that effectively moves the needle. But I think there also has to be buy-in from other constituents, and I say specifically the health plans, because if you look at the model here, you're looking at educating the various segments of the health plan that might be impacting care, and ultimately it will improve the efficiency of the care delivery as well as the outcomes, which, if things move in a way that they may, pay for performance and pay for outcomes, may be an important factor. So I think in order for this to have legs, and I'm hoping this is what may happen, there has to be buy-in by the health plans, because they need to see the win-win for them and the recognition that this can affect their efficiency, their ability to deliver good care, and ultimately their bottom line as well.
And then I'll just add to that. So I think that it has legs as long as we're within the CME community smart about it. You know, education is a vehicle to improve the quality of care and potentially improve outcomes. I think we all recognize that. But you know, as long as we're not, again, adding to the clutter, adding to the white noise, and also looking at long-term interventions that are tied to the system, then we can. The last thing that we want, I think that quality improvement is something that's been around for many years, where many CME providers are still trying to figure out what it is and how to accomplish it. And so again, we need to think about this in a very different way to ensure that it's adopted, and we're able to again demonstrate that this can, in the long run, improve patient outcomes.
Thank you.
All right, great. I am going to cut us off now because we are at our deadline. So thank you, everyone. I really appreciate it. 2 last quick slides. Please make sure you take our survey that we have so we can know who all has been watching and your opinions. There's a link right on our live page you can click on. And then lastly, just a reminder to view the next session coming up, which is More Than More's Alternate Methods to Measure and Report Outcomes Data. All you have to do is just refresh your screen, and you should be able to watch in a couple minutes. Thanks again to everyone, especially you, Wendy, and I will talk to all of you soon.
Thank you.
Thank you.